I'm really pleased to introduce the next group of people that are from Connecticut, that come here from Middletown, where they are part of what's called the Community Health Center Incorporated. And we've got their leadership here on the medical side, Dr. Daren Anderson, an internist like myself, who's been working at the clinic since 1998 there and leads their quality and innovation institute called the Weitzman Institute. And then Agi Erickson, who is the Project Echo leader for the Weitzman Institute too. And the two of them, along with their amazing staff, have been spreading Echo around the country for a long time. They've got mature chronic pain and substance use and MAT echoes that they'll be talking about. And a familiar face from this morning, Dr. Bennett Davis from Arizona, is leading their pain echo sessions, so he's going to be joining them on stage. So without further ado, let me welcome the Weitzman Institute, Dr. Daren Anderson, Agi Erickson, and Bennett Davis.
Well, we're in the final stretch. And I know if you're like me, right around 3 o'clock is when you start to fade. So we're going to try to pick it up a little bit, and we're going to talk about something a little different. We're going to talk about primary care. We've had a lot of specialists and a lot of people with expertise in pain, a lot of pain management experts. I'm a primary care provider. I'm a general internist, and in 1998, when I left residency, I started work at an FQHC. I was in the National Health Service Corps, and I was placed in central Connecticut in a town that was only about 15 miles from Yale New Haven Hospital. I was used to talking to specialists all the time. They were right across the hall. They were right in the next exam room. And I was used to being able to curbside and get advice about challenging cases. Even when I was working in the outpatient clinic at Yale, I was able to go see a cardiologist who I knew who was on the wards and show him an EKG or talk to somebody about a tough pain case. And the minute I drove 10, 15 miles north to New Britain, Connecticut, all that changed. And on my very first day of practicing primary care, I realized that I was a pain specialist. I hadn't learned anything about pain. In fact, I think one of our previous speakers said, you could count the number of minutes of pain training that we got on the fingers of one hand, which was about right. But despite that, I was a pain specialist because about 1 in 5 patients that I saw came in with chronic pain, and they had been being managed by my predecessor. With a wink and a nod, my medical director said, well, he's what we call a loose prescriber. So I knew I was in trouble. And one of the first patients that I saw, I remember he walked in the room, and we had these things we used to call paper charts back then, these big things with lots of information, and then that's how old I am. And I opened up the paper chart, and we had this thing called a paper problem list, and I was reading down that, and I saw cocaine abuse, I saw chronic back pain, I saw depression, anxiety, PTSD, every behavioral health diagnosis that anybody had ever thought of was on that problem list. And the chief complaint that the medical assistant had written with a pen on the piece of paper in the medical record said, chronic back pain, meds not working. That was the chief complaint. And so I, with much trepidation, leafed through, it was one of these charts, and that was only one of 3, leafed through, saw lots of MRIs, saw lots of referrals, neurology, orthopedic surgery, physical therapy, lots of no-shows, and basically walked in the room and basically walked into my fate, which was to become an expert on how to deal with patients like that. And I realized at that moment that I was in big trouble and that we, as primary care providers, anybody else who wanted to do what I wanted to do, which was take care of the underserved and work in a primary care office, was in deep trouble. Because what I didn't know then, that I knew after about a week, was that 1 in 5 patients that I would see, on average, would look and sound just like that patient. And I didn't know what I was doing, but I was a chronic pain specialist. So what I want to talk to you about today is a fundamental belief of mine, which I hope you'll share, and that is, at least by the end of the talk, and that is that we primary care providers need to become experts in pain care. I think we had a dream. We had a dream that we could treat chronic pain with a pill, because we're good at that. We know how to write antibiotics when somebody has strep throat and make it go away. We know how to prescribe different medications for diabetes and heart failure and generally make it not go away or manage it. But we have come to learn, and I don't need to say a word about the fact, we have learned that there is no pill that makes chronic pain go away. So now we've learned that that dream is not going to happen. So we have a second dream. Every primary care provider has this dream. And that dream is that we can refer this problem to somebody else. Like Bennett Davis. I would like nothing more than to have the Sierra Tucson Institute right next to my FQHC and to send every single one of these really tough patients to him. Because you've heard how they can do the amazing things that they do. But guess what? There aren't very many of them around. And in my state, Connecticut, there isn't a single one. And the one that there is actually only takes paying patients. So my patients are 70% Medicaid, 20% uninsured. There's no place for them at the chronic pain center with the multidisciplinary mega faculty. So I have a real problem. Neither of my two dreams, I can't prescribe it away and I can't refer it away. So by default, I have to be a pain management specialist and I have to be expert in this. And so I started thinking a little bit more about that. So one of my favorite conditions to treat and manage was always diabetes. Because working in New Britain, I needed to become an expert, not just in diabetes and insulin management and metformin and all that stuff, but I had to become an expert in what my patients ate. I had to know what their community was like, where they could exercise, where they could walk, who they could talk to learn about shopping, what kind of food was available. This is really what primary care is about. It's more than just learning pathophysiology and making a brilliant diagnosis. It's about getting to know your community and getting to know your patients. Many times it's about learning about the behavioral conditions that patients have, learning the impact of depression on eating habits. All of that feeds into diabetes. And yes, there's actually increasing evidence that a history of trauma impacts outcomes when you're treating diabetes. So if I can learn diabetes and build a multidisciplinary team to help me manage diabetes and do it well, I ought to be able to do the same for pain and pain management. And so as I've gradually shifted in my career from a full-time primary care provider to researcher and an innovator, we have been focusing on the tools and the techniques and approaches that you need to help your primary care practice be able to do what I'm describing. And so the Weitzman Institute, it's a research and innovation center that we built. It's part of our community health center. So we're a large statewide community health center located in Connecticut. We have sites across the state. We take care of about 130,000 patients, lots of them with pain, lots of them with diabetes. And around 2010, our leadership decided to build its own innovation center that would apply formal research methods, would get grants, would write papers, all the things that academic organizations do, but that we would focus on answering the questions that arise in the day-to-day delivery of primary care for the underserved. And the number one question that arises in the day-to-day delivery of primary care for the underserved is, how do I manage patients with chronic pain better? And so we have, almost by default, become a research center, an innovation center, focusing on how to manage chronic pain better for the underserved. And I want to tell you a little bit about how we've done that. And I'm going to say something that is, I don't want to say it's blasphemous, but it seems to run counter to what we've been talking about so far. Project Echo is not enough. So the first point that I want to make, that I hope I'll convince all of you of, is that primary care providers need to be the pain experts that are going to help us manage our way out of this crisis. The second thing that I'm going to say is that Project Echo is a fantastic tool, but that it's not enough. Project Echo provides very smart providers who know how to take care of pain. But if you're a very smart provider working in a dysfunctional system that doesn't have the tools and the integration of care that's needed, you're going to be a smart doctor in a system that doesn't work, and you're not going to be able to manage the problem. So what I want to do in the time that we have is talk about three main components of our pain management, pain quality improvement process that we followed and that we've developed over the last several years, and Echo is part of it. So I want to start by talking about Echo. I'm going to talk a little bit about asynchronous telehealth, and then finish with what we call practice transformation collaboratives, and show how we're beginning to pull all of these different tools together to build primary care centers of excellence in pain care. And if I've done that and I've convinced you of those two things, then I've served my purpose. So you heard a lot about Project Echo, and I have to tell you, Dr. Aurora is one of my personal heroes. When I was sitting on my couch in 2011 in the summer reading the New England Journal, and out popped an article that you all saw that was presented before, and I thought, wow, this is great. This is an article that shows that we can do better than the academics in the academic health center. What a great thing. But I don't have a lot of hep C patients. I have pain patients. So from the very first minute I read that article, I said, we need to figure out how to do that to help us manage chronic pain. So I flew out to New Mexico. I was one of the first providers to go and go through what they hadn't at that point called replication site visits. I came back again and brought my team. And we learned how to do what they do and created our own echo center within the Weitzman Institute. And at the time, we were the only non-academic center to do that. We were an FQHC that was actually broadcasting echo. We have, since we're large enough to be able to have a lot of internal experts on our staff, including some really good hepatitis C treatment specialists, buprenorphine specialists. And so we started doing echo from an FQHC perspective. And with all respect to the academic entities that put on echo, there's something unique when you have providers working in an FQHC, working in the safety net, something unique about their perspective and about the way they talk to the primary care providers and work with them and their understanding of that environment. And so we created this and we used it to tackle what I called our hotspots. Not the same as the Camden Coalition hotspots, but hotspots, the things that were driving our providers crazy that we were really struggling with, like pain, like complex care management, like buprenorphine. We did do hepatitis C. Our most recent echo, complex integrated pediatrics. We have a large team of pediatricians, of family docs, nurse practitioners taking care of some really complicated kids and needing assistance with that as well. The other thing that we realized at the time, we were in Connecticut, and there was not what I like to describe as a friendly neighborhood academic medical center that wanted to produce an echo and wanted to have one. So, I mean, we didn't initially decide to do our own, but we did after I called UConn and called Yale and said, hey guys, let's do an echo together, and nobody seemed to be very interested. And so my hypothesis at the time was there's probably lots of other federally qualified health centers and other primary care practices that also didn't have a friendly neighborhood academic center like the University of New Mexico. So we, from the very beginning, decided that ours would be national, and any provider that wanted to could join. We have a saying at the Weitzman that we need to make geography irrelevant. And so when we started signing up health centers from northern Maine and from Washington State and from Montana and from all over, we realized that geography really could be irrelevant, because even though people talk differently, our providers from Texas talk differently than our providers from northern Maine, they all had the same issues. And it actually became even more fun to have providers from all over the country presenting their challenging pain cases or talking about buprenorphine and opioid addiction. And so we built this national FQHC family of practices and providers wrestling with the same issues and gradually becoming expert in them together. And so the entire notion of force multiplication, of creating a community of practice and a family really took heart. And our echo has taken off as a result of that, and it's been incredibly fun and enjoyable to watch providers learn, to watch them share ideas from California versus Maine and everywhere in between. And so as of today, did we do our 2,500th case today?
Sure did.
Yeah. So we've had 2,500 case presentations, individual patients who've been presented to one or another of our echoes. And we have practices from 28 different states and the District of Columbia who have joined with, you can see the numbers, large number of medical providers being supported for one or another of those echoes. But our most popular, I think it's still true to say pain is our most heavily subscribed, but buprenorphine is a very close second. Because as the knowledge about the opioid epidemic and the challenge of pain management has continued to grow, and as funding has come in to support those things, there's increasing need around the country for those, as you heard before. So this is the slide that summarizes the point that I want to make. And that is to do what I said and to take a primary care practice and make it a center of excellence for pain care, it takes more tools than just Project Echo. And so this is a graphic of the different tools that we use in Connecticut at the Community Health Center to help our providers and to help our practice scale up and gear up to take on and manage effectively the pain and opioid crisis that we're facing. So buprenorphine echo and pain echo go hand in hand. You need both. And as of today, we have 21 providers across our network that provide medication-assisted treatment and are supported by Project Echo. We have supportive websites. We call it AddictionNet and PainNet, where every single echo session that's ever been done is recorded and cataloged based on the topic of the cases, and the topic of the didactic. So even if you don't have time to join our echo because you're in a different time zone or because your CFO won't let you take an hour and a half off to attend echo, you can watch it, you can listen to it in the car. You can search if you have a challenging case of fibromyalgia. You can type in fibromyalgia on PainNet, and any echo session that talked about a fibromyalgia case will pop up and you can listen to it. Anytime Dr. Bennett Davis or the faculty on pain recommend a particular article or a tool or an assessment tool, we post it on PainNet. So we have a virtual library and really an encyclopedia of expertise on pain that providers across the organization can refer to, and AddictionNet does the same thing. But the other thing that we found is it's great to be able to present a case at Project Echo, but they only occur every 2 weeks. That's the most we can convince most medical directors to allow their providers to take off. And there's limited number of slots to present a case. And so if I'm seeing somebody today on Monday and I have a question about how I should taper them or what my next approach should be, I may not be able to wait for the next session, and I might not even be able to fit in. And so there's also a need for rapid transactional exchange of information, quick questions. We used to call them curbsides. And so we provide, as a companion to Project Echo, what we call e-consults, asynchronous electronic consultations, and we built a whole network. We call it CECN, the Community E-Consult Network, which by using simple technology, your electronic fax out of your EHR, direct messaging, even secure email, the clinician can send a question to our echo faculty or to an orthopedist or to a neurologist. We actually have 35 different specialties now that are taking part in CECN. They can send a consult with the information out of the medical record and get a response back in 2 days or less. And that, as a companion to pain echo and buprenorphine echo, but also as a tool to get quick turnaround for specialty consultation questions, has been transformational for our practice. It's actually led us to reduce by almost 25% the number of specialty referrals that we require. And the other component is practice collaboratives and really building a system to really help the practice embrace new processes, train your medical assistants, things like that. And we're going to talk about all of these in a little bit of detail over the course of the next several minutes. So I would like to, our secret weapon, and despite everything that I said about echo, it is a very important cornerstone of our intervention. And our secret weapon, you already heard today, Dr. Bennett Davis. And being able to have Dr. Davis and his expert multidisciplinary team of pain specialists in a variety of different areas talk to us about cases, give that same didactic that you heard earlier, but talk about it case by case is an amazing, amazing resource and opportunity. And so echo needs to be a cornerstone of transforming your practice. And I'm going to let Dr. Davis talk a little bit more about pain echo and how we do it, what it's like. This is our curriculum. Dr. Davis, I'll let you talk a little bit about that, and then I'm going to show you on video.
Oh, on video?
Absolutely. That was what you heard before.
Well, here
that was you.
I have a voice.
Yeah, I have your better voice.
Yeah. So
Is your mic on?
I think this is on. Yes. Yep. Thanks. So a little bit about the curriculum, and then the faculty. The curriculum for a program like this is always at risk for getting kind of drifting to suit the fancies and preferences and biases of the faculty. And so early on, we realized that we needed to create a curriculum that was based on some core principles. And the group of ECHO faculty that we pulled together and a number of other experts got together and published a core curriculum, actually a core 9 best practices for primary care pain evaluation and treatment. That's in Pain Medicine, I think, is the journal. And that took into account a fairly recent publication of a curriculum, a core curriculum for training in pain, really more geared towards managing opioid. That I don't know if our colleague from UC Davis is still here, but Scott, yeah, and that was largely influenced by the folks at UC Davis. It was a national effort really pulling together a core curriculum. We took that into account and a number of other principles. We wanted to come up with things that would endure. We would train people in competencies that were enduring regardless of changes in biology and science. We did want to give people the latest information on medications and procedures and so on, but we wanted a curriculum that would endure regardless, and that would be relevant to insurance companies, to people who are paying the bills, to the patients, to policymakers, and so on. So in that paper, we defined a set of criteria, and we put together 9 best practices that we actually have. It's kind of hokey, but it's up on a little, up on a big poster board underneath the TVs so that all the ECHO faculty can kind of see those and make sure that we hit at least a couple of the best practices for treating, evaluating, treating pain in primary care on each case. Otherwise, it's too easy to drift. And there are things like keeping care, obvious things, keeping care patient-centered, knowing who the patient is, and that may seem easy, but it's not. You know, one of our favorite questions when echoists are beginning is, tell us about a day in your life of your patient. How do you think people often respond to that? I don't know. It's a 42-year-old white female with, you know, no, they don't know anything about the patient. So that's one of the points that we drive home, and it gets down into how do you assess a patient for the psychological factors? How do you screen for psychological factors that may be driving somatic complaints, including pain, may be driving their medical conditions, and so on. Understanding what pain is, we talked a little bit about that. That talk that I gave earlier is similar to one of the didactics that we would give them. Knowing when to refer, how to refer, who to refer to, that sort of a thing, how to make a team around the patient. So in our concept, this isn't just limited to treating pain, but for treating pain in particular, you need to build an effective care team, and that can include engaging behavioral health, physical therapy, all those sorts of things. So we train on how to do that. Obviously, that would be an hour talk on every single patient. So it gets kind of tricky in that each case presents a couple really salient points, and we'll try to hit 2 or 3. But over the course of the series, they'll hear the same messages over and over again. In particular, the integration of behavioral and medical. And really, if there's an overarching theme, it is integrating behavioral and medical, reintegrating those 2 specialties. And the faculty for this, when they picked us, they didn't know they were getting it, but they got a group of healthcare providers and behavioral folks who had been working together for over 15 years. So I've been joined at the hip with a health psychologist who ran one of the Backrack Institute in New Jersey for 10 years. That's an inpatient, outpatient, rehabilitation program, functional restoration program. She actually ran that for quite some time until it went out of business because it became unfundable when insurance changed. So we have this experienced psychologist who kind of taught us the ropes of how to integrate behavioral and medical, and now we teach that by demonstrating it and discussing the case as we would any of our cases. As a matter of fact, ECHO typically would follow our own interdisciplinary rounds. So we would talk about our own patients, talk about 4 or 5 or 6 of those, and then we'd switch into ECHO. And it was just a couple more cases, just like the ones we just talked about, except we were hitting heavily on the teaching. We have an addictionologist, a physical therapy comes in and does cameos for this. We have a complementary alternative medicine gal who is also a hand therapist, occupational therapist, and a trauma therapist. So she covers a lot of ground. And a nurse practitioner who's worked with us for a very long time. I don't think I'm forgetting anybody. That's the main faculty that will slice and dice these cases. And the lessons that we've learned, really, kind of the overarching lesson again, is that our students don't know how to screen for, they don't know that this is probably one of the most important questions when you're dealing with a person with chronic pain. Or when you're screening a person who's going to have a major surgery or is signing up for a major surgery and may need opioids and rehab afterwards. To what degree, the question is this, to what degree do psychological factors drive this person's pain complaints, somatic behaviors? And if it's mostly psychological factors, what are they? Second question. Third question, what can we do about them, if anything? So we teach, those are the 3 main questions. We didn't realize the degree to which primary care was sort of adrift. with not even knowing to ask those questions, not knowing how to ask them, not knowing the tools, not knowing how to approach a patient without worrying about upsetting them, that they're implying that the problem is in their head. So it was mentioned earlier about teaching providers how to talk to their patients. That's a very strong theme, it's going to be in any pain echo and in ours as well. I guess the last thing I would say is that what we have noticed in a lot of our echo sessions is a strong chat going on in people that we might have echo providers in a community in a small town in Colorado. They might be chatting with an echo provider who's 50 miles away in another town, an echo student in another town, and talking to each other offline on the echo chat as we're talking about cases, about resources in their community. As I heard Dr. Crow talking about networks of excellence, I've seen echo create the core, the foundation for networks of excellence amongst the primary care and behavioral providers talking on the echo real time in real life, and that was a very cool thing to see. And I think if we leverage that even further, we're going to see that the echoes set the foundation for the providers who know what to ask for, are now connected with each other, and are now sharing information that will go offline and continue, and something that we support.
And just another quick comment that, this is very evident that managing chronic pain is very complex and challenging for most primary care providers, and the research does show that providers have very little confidence in their ability to safely and effectively manage pain in primary care. And certainly this is also backed up by the education or the lack of education that providers receive in medical school. Yeah. And the only tool that they have very often is a prescription pad. So that was not very helpful. And knowing all the background information that we heard earlier, the New England Journal of Medicine, that very brief letter including the fifth, pain as a fifth vital sign. So all of this led to what can we do? And we've been on the journey of providing medical care for 45 years. At Community Health Center, caring for 130,000 patients. And as Daren stated, there's a great variation in care that's being provided. We had providers who had very little prescription opioid prescribing, and we had some that were very generous with prescribing opioids. And we wanted to find an evidence-based model to reduce that variation and offer tools to the providers that can be in their back pocket. So ECHO to build your knowledge, build the scope of your practice, and have e-consult where you have a quick question, you have someone who can respond to you in a very timely manner. This is a national public health crisis that we're dealing with, and we do need all hands in deck.
I did want to add, because I didn't say it, I should say it out loud. Another lesson was, no one will be surprised, we didn't realize the degree to which primary care didn't know how to safely prescribe and manage pain medication. So obviously I need to say it out loud because it's sort of implied, but no, it's not. That's definitely a big part of each echo. A lot of the patients presented are on pain medications of different types, and the main question is, what do I do?
So if we have time at the end of the presentation, I'm going to actually make a little bit of a diversion and talk a little bit about some of the research that we're doing, because I think one of the critiques and criticisms of Project ECHO is that a lot of the energy and the excitement and the spread has been built on anecdotes or on knowledge surveys and satisfaction surveys, and there isn't that much rigorous science other than the New England Journal article that's been seen. And so we've been trying to address that and to put out more robust research designs to look at the actual impact of ECHO. This is one that I thought was exciting because it really confirms a lot of what Bennett has been saying. We have a qualitative scientist who, working with a medical student, watched 30 or so ECHO sessions and coded every single thing that Bennett and his team said and every guidance and recommendation that they made, and then did content analysis to really to group them into themes, and found, probably wouldn't be a surprise to anybody who's attended these, but the vast majority of the ECHO sessions talked about non-pharmacologic therapies and non-opioid pharmacologic approaches, non-opioid approaches rather, to in managing chronic pain. You can see a couple of other sprinkling of things like dosage and frequency, but at the bottom, 40% of the time, 40% of the recommendations were addressing issues, confounding psychosocial confounding psychosocial issues that were embedded in what they were talking about. So, and we're going to be doing more robust analyses of the types of things that are coming out of these echo sessions and the types of things that primary care providers want to know. So I want to shift gears in the interest of time, if this will advance. And I talked a little bit about PainNet, but I want to, Agi has already introduced herself, but Agi Erickson has been at my right hand since that first trip to New Mexico and is the director of our Echo Institute, of all of the echoes that we produce. She is the person who has figured out how to make every single echo, every single session, every single time high quality, both from a visual perspective, from a content perspective, curriculum perspective, and a technology perspective. And she is responsible for all the different faculty, coordinating them, making sure that they show up, that they have their slides together, and that this computer is doing what it did before. It's advancing on its own. I apologize. So I'd like Agi to talk a little bit more about some of the tools, about our buprenorphine echo, about PainNet, and to describe a little bit more some of the other components of tackling the opioid epidemic that I was speaking of.
Thank you, Daren. And a couple of questions that we were asking as we were preparing to launch our echo shortly after Daren's visit to New Mexico, visit with Dr. Arora, was, so who's the audience? We wanted to ensure that, addressing the opioid crisis, we knew that we had to engage the behavioral health community. So not only the medical providers were invited to join, but also the behavioral health providers and any care team member. It was mentioned earlier that addressing the opioid epidemic has to be a team sport, and indeed it is. So we are very pleased. Every time we have a new site joining, we're asking them, do you have integrated behavioral health? If you do, please ensure to extend the invitation to the behavioral health providers, because we were looking at the integration. Integration is a big buzzword, but are we really truly doing integrated care? So I think when you see on the screen a medical provider and the behavioral health provider side by side presenting on a case and getting advice from a multidisciplinary team of specialists on how to go forward, that's the true integration of care. So we've been very proud. And also, if you have a clinic where you don't have integrated behavioral health, but you are working with behavioral health clinics, we ask them, please extend the invitation to those. Let them join as well, because you are collaborating and working together, and you have to address both the body and the mind at the same time. And in terms of the tools, I have mentioned very often providers only had one tool, which was their prescription pad, which also led to somewhat to where we are right now in the crisis. So we believe that providers have to have as many tools as possible at their convenience, use ECHO to build their knowledge, and have e-consultation, but also have websites where they can go and they can look at resources, look at tools, download them, and use them. And this is all at the provider convenience. We have, after the first couple of sessions, we have realized that every echo session is a gold mine. There's so much wealth of knowledge in every session, and that was, as the session went and was gone, everything is just gone and disappeared. So we have invested very early on in recording all these sessions, and we created a website for every echo that we have. We catalog the didactics and case presentations, and these are available not only the providers that are participating in the echo session, but the entire clinic. And then I'm saying that for the entire clinic is because in a fee-for-service environment, you cannot take all the providers out from seeing patients just to be on echo, but we have to be diligent, and usually providers have to rotate who's in echo, but the rest of the folks have access to all this content that's easily searchable. So again, PainNet, AddictionNet, these are all websites that are password protected and are available to all the providers and their colleagues at the practice sites. And the buprenorphine, so as soon as we started Pain Echo in January of 2013, and February 1st, we started buprenorphine Echo. Again, we need all hands on deck, and we're really excited that the community of waivered providers has been growing, including NPs and PAs. The challenge is, and what we've been hearing from medical directors across the country, is that you have providers who have great intentions, they go in there, get their waiver, they start seeing their first, second patients, and they have so many questions, so many gray areas, and there's nobody who's watching their back. And this is where kind of care stops very often. And providers are fearful because this is an area they have not been practicing, very challenging, very complex. And having an echo that is available and many other tools and resources where you can ask questions, you can present your case, not just clinical questions, but programmatic questions as well. It made a real big difference. Just at our community health centers, a community health center in Connecticut, we have provided buprenorphine to over 1,700 patients. And also, this is a community, and providers want to be part of a community, no matter if you are in an urban setting or a rural setting. Especially in a rural setting, providers feel very isolated. And talking about the quadruple aim, this also, we believe, that helps with provider satisfaction and retention, where you don't feel alone, you feel connected, you're connected to your peers, you're learning from the faculty, you're learning from the colleagues, you build friendships, and you have a lot of folks that you can connect if you have a question. So we truly believe that having access to these tools and resources is making care much better, making care available in a timely manner, and we are on the road to provide safe and effective pain care in primary care.
Awesome, thank you very much.
We've just got a few minutes left, so if you got questions.
No, we're not finished, I'm sorry. No,
okay.
we're still...
We have another section.
Okay, let's go.
Yeah, all right. So the next piece that I want to touch on briefly is e-consult, as I mentioned. And part of what we've created, as I said before, was the ability to link primary care providers electronically so that they can ask questions and get a quick turnaround answer. And so e-consult, CECN, simple concept. We have an expert faculty that's available to answer. They have 2 days to turn it around, and we give the primary care providers the ability to link up either through electronic fax, through direct messaging, a range of different ways so that they can get an answer. And I just want to show you, this probably is too small for you to see, but this actually is a consult from Bennett about a 47-year-old patient that he consulted on, gave a very detailed response, and was able to get that back in the primary care provider's hand within 2 days. And so the combination of those two, listening and gradually building your expertise, but being able to get answers to specific questions, is a powerful combination that we're increasingly utilizing with our ECHO networks. So, and then the last thing that I want to touch on, I actually think this is one of the most important missing pieces that we haven't talked about today that I really want to focus on. If you're going to build a system to take care of patients with chronic pain issues, with opioid addiction, if you're going to integrate buprenorphine treatment in your primary care practice, you need a team. Your nurse, your receptionist, your medical assistant all need to be fully versed in the different tools and approaches you're going to need. You'll need integration of behavioral health. You'll need to build in screening for trauma, for depression, for anxiety. You could talk about that during an ECHO session all day, but it's not your expert provider who's going to be implementing those things. So we've designed an online practice improvement collaborative, and we've done this now on 2 successive waves, actually in the state of New Jersey, to teach primary care practices how to manage pain and how to embed some of these things, some of these tools in their practice and into their workflows. So the people who do the learning collaborative are not Bennett Davis, Augie Erickson. They're actually quality improvement people who know things like flow mapping, who've learned about lean and can do a PDSA cycle. They're people with expertise in quality improvement. And you can see from some of the pictures, they work with teams that are largely comprised of frontline staff and learn how to embed urine toxicology screening into your practice. What's the workflow behind that? How do we make sure that the prescription drug monitoring website has been checked for every single patient? And they set specific goals. They teach measurement and how to capture data and how to track your progress. And as the primary care provider is participating in ECHO, these teams are working to embed some of the best practices into their day-to-day work. We use an online system called Moodle, which is a learning management system. We've built modules that can be self-directed or can be guided. And these are some of the things that they talk about. How to embed screening for for function into your practice. How to embed behavioral health screening into the assessment of each patient with chronic pain. How to provide effective patient education for patients with pain. You get the gist. These are basic core items of pain care that most primary care practices don't have. And we spend a lot of time on measures and measurement and how to actually capture this data in your EHR. How much time do we have?
Technically, we're over, but...
Okay, so we'll stop with that. I'd be happy to talk with anybody about some of our results. We have a lot of research that we've been doing. We published some papers about Project ECHO and about the collaborative and some of the outcomes that we've seen. Suffice it to say, most recently, we published a controlled trial looking at a cohort of providers who did ECHO and a cohort of providers who didn't. In addition to showing acquisition of knowledge and self-efficacy, we actually showed increased referrals to behavioral health, reduction in the use of opioids, an increase in referrals to physical therapy, which we were excited to see. And so that's the type of work that we need to really start focusing on if we're going to make the case to our payers and to others that this is an important component of care. We need to show hard outcomes, not just knowledge and self-efficacy, but actually an impact on patients. So with that, I will end, and I thank you very much for your attendance and for your interest.